Good afternoon, everybody. Welcome to our session today. I'd like to thank you all for joining us this afternoon. My name is Jennifer Horowitz. I am the Senior Director of Research with HIMSS Analytics. I've been with the HIMSS organization for 12 and a half years, and I head up our research initiatives. I am very pleased to have been asked here by Carestream today to facilitate a conversation with our panelists about your organization's imaging environments. And we're going to be talking a short-term strategy, long-term strategy, PACS images, scanned documents. And so what I'd like to do is start off by asking our panelists to introduce themselves. I will go through some points, and then we're going to have our panel conversation, and we'll leave some time at the end. We certainly welcome your questions and dialogue with your questions. So Tanya, if you don't mind getting us started and giving us a brief intro.
Hey, my name is Tanya Reeder. My first bachelor's is in nursing. I work now as an IMO in our IT shop. So we have ITD, so CIO, a Chief Technology Officer, and the Chief Information Management Officer, and I'm the Information Management Officer piece of it. I work at the greatest hospital in the world, the President's Hospital, where we take care of wounded warriors that come back from the war in Iraq and other wars.
Excellent. Thank you. John.
I'm John Showalter. I'm an internal medicine physician. I'm also board certified in clinical informatics. I'm the Chief Health Information Officer at the University of Mississippi Medical Center, which is the only academic medical center in Mississippi. So we are a big referral hospital from rural areas.
I'm Steve Saris, the Chief Information Officer at Baptist Healthcare in Pensacola, Florida. Baptist Healthcare is the only independent community hospital between Mobile and Tallahassee. So we are in the panhandle of Florida there, where the Naval Air Station is in Pensacola. It's a great area, but a lot of the hospitals are really owned by the big players in the country.
Good afternoon. I'm Michael Cohen, and I'm the token Canadian. I'm the Vice President of Clinical Services and Information Management, CIO and Chief Privacy Officer, which is short in Canada for you missed a meeting. I'm also the Executive Lead for the Diagnostic Imaging Repository, which we run basically a shared environment to share diagnostic images across the province of Ontario.
Excellent. Well, thank you very much. Before we get into the panel conversation, I've got lots of questions today. I just wanted to give you some background. As I said, I work for HIMSS Analytics, and so I took a look at our database and just wanted to share a couple of statistics with you today about imaging and share that information. So with regard to radiology PACS, as I looked back at our data, HIMSS Analytics has had data since about 2004, and I used 2007 as my benchmark point. About 70% of U.S. hospitals had installed at least one PACS modality, such as CT scanning or digital mammography. Today, that's over 90% of hospitals. And the types of images that PACS environments are taking now has increased exponentially. So storage of those images is a much greater issue that healthcare organizations are facing. Cardiology PACS has seen a similar increase. In 2007, we saw that about 1/4 of U.S. hospitals had at least one of the cardiology PACS modalities that we tracked installed, and today we see about 2/3 of U.S. hospitals have installed that technology. So again, a nice incremental growth of that type of technology. And we also are seeing a use of PACS in a number of other specialty departments, ophthalmology, obstetrics, in the ED. And so, another group of images that healthcare organizations are having to learn how to store and manage. And then we've also seen, as we've digitized medical records, healthcare organizations are having to deal with that segment of their medical record that's paper. So that might be the referrals that are coming in or information that they are simply trying to scan and get into their environment as they get rid of their paper medical charts. And so that's another component that I'd like to make sure that we are addressing today. So with that context in mind, the first thing that I would really like to ask of our panel today is, how would you characterize your organization's approach to managing patient-related images, and what are your plans to incorporate all of your images into your electronic patient record? And if you can make sure that you're also elaborating on who your vendors are as you think about that answer, that would be great.
I'll start off. We have a very patient-centered approach to our imaging. We had a unified PAC system which was Philips using eyesight until 2 months ago when we acquired another hospital that has GE, and we're still figuring out our strategy with regard to integrating that, whether we're going to use a neutral archive or convert them over to Philips. So those are still in discussion, but we have a critical access hospital that we laid a high-speed pipe to, so that they're actually sending images down to our central PACS and reading from our central PACS, and have our radiologist at the main hospital doing all of their reads. We have integrated all of our other images into our EHR, so our photos are currently going directly into our EHR storage. We are now in discussions about going to enterprise content management. We have some hard limits on storage with our EHR, which is Epic, so we are trying to get those larger files off and into a different system, expecting to tackle that in the next 12 months.
Well, we also use Philips Eyesight, but it's under a GE contract, so it's a little different relationship. But it is a complete enterprise PACS, and it is integrated into the RIS, and we support 4 hospitals with that PACS system. Our strategy at Baptist, it really is a strategy, although it is sort of a little bit of a laugh, because its lowest direct cost, and our replacement strategy for any modality or IT piece of equipment is essentially Grim Reaper. We really run things until they either are not safe for the patient, or until they break, or until there's really a dramatic improvement in modality or patient effectiveness. And so we really have a strategy to make sure everything's plugged in and working well. But we definitely are not bleeding edge on most fronts, and we make our steps forward in pretty big steps in terms of not being a market leader necessarily in technology. Although we did get ahead in digital mammography, and that's a long story in terms of how big those images are, and that did present us some challenges in our current environment in terms of just adopting some of these new modalities that really are harder to handle than we expected. I would share that you were talking about the statistics in terms of migration to PACS. One of our rural hospitals in Alabama, in Florida, the rural hospital in Florida just went and got rid of its last film last year. So again, we really do things in a very judicious and budgeted manner, and we believe again the enterprise PACS system is doing a great job for us. The radiologists use it very effectively. Again, it's not the state-of-the-art viewer, but again, it works every day. No distractions for the radiologist, and I think we're making good progress toward making decisions for the future across more of the enterprise PACS, linking in the cardiology and those other modalities as well.
Excellent. Michael?
So we're a Carestream shop. We're fully digitized and archive our own images locally on site. We also are sort of probably unique. We provincially, we have a diagnostic imaging repository that converges about 70 hospitals across Ontario that we also feed. So the repository, which is separate from the corporate infrastructure of the hospital, actually serves as a backup, but it also allows us to retrieve images from a very significant geographic distance to support patient care, so that we don't have to send copies or CDs when we transfer patients in and around the area that's shared under this repository. And that's part of a provincial strategy that set up about 4 repositories across the province of Ontario. We run a Meditech 6 environment, and so all of our PACS images flow through that and are viewable within either PACS or the Meditech environment.
Tanya?
So for us at Walter Reed Bethesda, it's a little bit more challenging because we have, just like they do, multiple organizations, but not only do we have DOD facilities, we also have Army facilities, Navy facilities, and Air Force facilities that are not just in the U.S., but actually all over the world. Like there's a big hospital in Germany that receives a lot of the patients before they either come to us or another military trauma facility. At Walter Reed Bethesda, we actually utilize ACFA PACS for our radiology imagery, but in cardiology, they use a GE PACS system. So there's multiple different types of PACS flavor. The way that we're trying to actually integrate everything is a vendor agnostic solution called HIMSS. It's something that we built because we thought it was great to build something called Health Artifacts Imaging Image Management System. And what it's going to do, and what we look forward it to do, and the reason I'm saying look forward, because we're actually implementing it now, is take all of these different vendor DICOM images, gift images, tipped images, whatever kind of images you can think of, put it into a central repository that's in San Antonio. But each site, each major hub site, like Walter Reed, will also have its own regional database. So that way, for the Walter Reed specifically, we have 27 children's sites behind us. So those 27 children will then tap into us. And if they need to then see data that's in Germany, then they can jump from us to the Germany data.
Excellent. A number of you have touched on how you're storing your images right now, and John, I think it was you that mentioned that that's becoming a real challenge, particularly in your environment and having enough storage space available to you. And I'm wondering if you can talk a little bit more about that and talk about some of the solutions you're considering to alleviate that issue.
Sure. So when we get into diagnostic imaging, at least for us, we do expand beyond just radiographic imaging. We have a large pathology department. We've actually started doing pathology for other areas in the state. Those visual light files are very large. They don't wrap very easily in a DICOM header. We also have our cardiology dumps directly into our packs, ROB dumps directly into our packs, and there may be some other less expensive solutions than putting those ultrasound images into a classic packs. And we just keep storing them because as a state institution, if you read our rules and regs very liberally, we have to store the images for 5 to 7 years. If you read them conservatively, we have to save them for 28 years. And we have read them conservatively. So we have every radiographic image for the last 15 years still stored on a server. And we don't have them tiered yet. So we have a very expensive solution for not improved patient care. So we're looking at upgrading to the newest version of our PACS vendor that will allow us to do some tiering, use some cheaper storage for the old images. We're looking at enterprise content management, something along the lines of on-base that will let us store our images as well as our scanned medical records files and still present them to our nurses and physicians through our EHR. So there's still one access point for our docs because they don't really care what we run behind the scenes as long as they only have to click one place to get it. So we are reaching out to try to take a real enterprise look at anything that is not a scanned text file and figure out how to bring it and present it with the patient.
How about others? What challenges are you seeing in your storage environment right now, and how are you looking to be able to address those, and what solutions are you exploring?
Well, we're much smaller than Ottawa. I'm excited about things that are coming together that are really standards-based across the vendors now with deduplication and the lower cost of drives, the storage array management. All that technology is really getting to the point where it's much more affordable per terabit at a good time because we're going to be using so many more terabits. And so we're going to, the investment that we make in our next, well, we already got all the infrastructure for the storage arrays, but as we invest, we will be looking at putting in place some type of management for the archive. I don't know that we would keep things for 28 years, but we want to know when we can remove things. And I think that's something that has hit a lot of people where they've been storing images and they have never put a real flag on it to go back through and clean it up. But I think those technologies are emerging too. So I do think we'll get through a rough couple of years here and then really get onto a point where the vendor systems especially have caught up with that categorizing and coding. And I would just say the visible light images are interesting because they are large. They don't wrap well. And even something like an EKG strip, it's interesting because in our medical record systems, we had a folder system and the doctors would know where to go get these documents. And then you put an EKG strip and we have it in there, but it's not really where the doctor might think it should be. And so these visible light images going alongside of the reports are really creating a need for us to go back through and look at our whole filing system in the medical record to really accommodate all the new opportunities really for for the doctors to have these images.
I think you touch on a good point, because for us, like, with the repository, we did envision that it would be a way to share information, to be portable and provide care, but we also envisioned that it would help us deal with some of the storage issues and archiving issues. And what we find is that, the docs don't like going into a separate system, because unfortunately it's not Carestream system. It's a GE product with the OneView, and it doesn't have pre-analytical, fetching of images, so you have to go find a patient, and it doesn't allow you to ingest it into your packs, right? So they like to use all the tools and measurement systems, but they're basically looking in two different systems. So it really isn't a viable strategy, at least at this stage, unless you have full ingestion into images. So that's one of the things that we're looking at, is the ability to pull images. You can identify, look at it quickly, and then if you want to really mess with an image, pull it into your local packs, and then create additional storage issues. But luckily, the cost of storage is going down in the short run. As you correctly point out, the strategies for archiving need to come along and help us manage things a little bit more effectively.
The next topic I want to talk about, and that's the retention policy. You mentioned some state guidance and how you interpreted that, dictated how long you were going to store solutions. And I'm really curious to understand if your organizations are putting in place formal image retention policies at this point, and if you are putting in place those types of policies, what do they include, and what are you looking at as part of those policies?
Well, I can speak for Walter Reed Bethesda. For us locally, we typically, the policy that we're supposed to keep the images are 7 to 10 years. However, understanding that most of our user base will end up, after they're discharged from the military, will end up going to VA system. VA, the whole DOD VA collaborative, would like to also get to those records. So the DOD stance is 75 years. The challenge with that is that the VA and the DOD, because even though we're still government, we're two completely different types of government. And to make sure that all of our images and all of our data are talking together, and all of our metadata is accepted between back and forth, or basically people can transverse between two systems, is what our biggest challenge is right now.
I say, what we'd really like to do is to put those images someplace cheap where they would be retrievable when we needed them, if we needed them, and we could prove to the state that they're retrievable. One of the challenges we have is that most PACS pricing is, at least that in our discussions with our vendors, is about when you pull them into the system, and we don't want to pay to pull them into the system multiple times. So I think, we're entertaining having discussions with our vendors on completely rewriting our contract so that we aren't paying as a pull image price to pull them back into our packs. And we have an agreement with them now where they're maintaining almost all of our systems, because we had a very decentralized model when we wrote that contract, and radiology was supporting the packs, not our IT department. So they have a full service agreement. So I think one of the challenges with these retention policies is, how do you partner with your vendors? How do you get your contracts written to support what you want to do with the deleting, archiving, offline storage? And at least from my perspective, those have been very early talks, and the vendors aren't even completely sure why we would want to do that.
Yeah, I think the vendor contracting is a very interesting issue, because they're not keeping up with the industry in terms of where we're going with the storage. And where I've been before, and at Baptist, we have policies, and I believe it's, the children are different. It's age of majority plus, I think, 5 or 7 years, and everybody else is 5 or 7 years. Our challenge is we have those policies in place for both PACS and for our medical record itself. And we don't have the ability, like in the old days, to go out and move through the paper and just throw last year's away, that annual inventory and purge. So in the old days you have those big buckets and they collect the film and go take the silver out. But we haven't done that, because we don't really have the flags on the system, because we can't just go in and say delete everything that was created at a certain date, because it might have been read more recently. And I think it's our issue is not to just delete it after 7 years, is to delete the ones that haven't been read in 7 years. So those are the kind of things we're trying to figure out and get a vendor to support in terms of putting together some sophisticated protocols to do that.
You said it all. We have the same challenges.
Are any of the federal regulations out there that you're facing, HIPAA, meaningful use, anything that's coming down the pike, are those affecting the way that you're looking at storage, that you're looking at your policies? Are you making any specific changes in the way you're looking at imaging because of that?
I don't think we're doing that any more for imaging than any other aspect of the record. The funny thing about the VA and the DOD, because we're in that military community, our doctors are always wondering why we can see the DOD in our HIE, we can't see the VA. And it turns out the VA, being different, has an opt-in where the DOD is just available. And so those kind of things affect people's effectiveness of the image, because the doctors won't go there if they don't trust that the image is going to be there. And so the VA DOD is an example where it just distorts things in the doctor's mind about whether or not we have the image online or not.
I'm curious to know how cloud technology is impacting your storage, the storage solutions that are available to you, how you're considering the use of cloud technology, and what your thoughts on that are.
We haven't deployed the cloud. For us, the repository is as close as the cloud as we're going to get, and and it doesn't, like for us, we want to be able to control the PACS. Like our PACS, maybe it's because they hang around with radiologists all day, but they're kind of paranoid, and the people that work in the PACS administrator's office like to be able to control it directly, and I don't think they like the idea of having somebody else just load the software from the Ethernet. So for now, it's not something that works for me.
So I think our biggest challenge with the cloud is thus far their viewers don't compete.
Mm-hmm.
So, I mean, the standard PACS viewers, they've had years to develop all of their tools and their 3D renderings, and our docs are used to them and they don't want to switch viewers. And what would be a good cloud solution for us is to be, that's where we push the stuff we're not using and that's where we pull it back from. But, we don't have those set up yet, and I've only had one vendor when we discussed that even as a possibility as something that they would consider, because it makes them much more of just a storage solution and not a replacement for your PACS.
I also have questions. I mean, all the cloud people would argue and tell me I'm 100% wrong, and they might be right. But we just went through our own enterprise internally and found that with the digital mammography and the larger CT scans, we had to put all of our servers on at least gig or 10 gig switches. So 100 megabit wasn't fast enough anymore. Yeah. And so you're going to end up with a local cache in today's day and age, no matter what. And that cache is going to be pretty big. And so you got that technology you have to have local. And then really with the cost of these arrays and the way the NAS technologies are going and with deduplication, that competitive edge of somebody thinking that they're going to get a terabit for a lot less than what we can buy for ourselves is that discrepancy is not that big anymore. And so then when do you want to tackle the control issues and some of those other compliance and security questions, or do you just go stay local?
Yeah, and I can tell you with the repository, there's all kinds of great things you look at, but all you need to do is get a radiologist to flip open a CT of the head, and they start to try and scroll through it, and the caching slows them down, and they go, okay, pull it in. So even if you have some sort of cloud solution, regardless of the technology, the radiologists are going to be saying, okay, well, somehow I need to pull this into my PACS. How do I do that, right? And that kind of negates the whole principle of having something that's out there, out on your own, right?
You mentioned workflow issues, Michael, and that's something that I want to talk about is, we've got all these images, we've got them in the electronic record, we're storing them. How are you making sure that the clinicians have them when they need them and they're accessible? And are you having to do anything different for different specialties or different types of environments? And how are you managing the workflow?
So for us, I mean, it's trying to reduce the number of clicks, right? So I mean, the radiologists are great; they just sit in a dark room and access PACS all day. But when you're looking at specialists and emergency physicians, you need a device strategy that's quick and easy that enables them access with minimum disruption, and you need to give them quick access to simple, in this case, images, or more often than not, reports. So reports are easy because you just look them up on your wrist. But anything that reduces the complication or takes you farther away from your health information system is bad. So anything that can be integrated into your HIS, anything that can be done easily, quickly through HTML or just presentation software is what we're looking at to be able to minimize the burden of, to just reduce those clicks, because they'll count every single one of them to get to where they want to go.
One of the things that we've done at Walter Reed, or DOD in general, is with the HIMSS product. It's integrated into our electronic medical record for our outpatient and inpatient. So there's an extra cute little button that says HIMSS that you click on that has single sign-on make sure that you're still on the same patient. So if you're in the electronic medical record, you click on the button and then you can see the image.
I think by far the best thing we did with workflow is we embedded a link in every one of our radiology reports that says show image, and you click on show image, and it takes you directly into our wrists, into our packs, and pulls up that image on your screen. And then you can go back and view older ones, but it pulls up that one right away with a single click from the providers. They love it. It was apparently extremely technically challenging, and our radiology gurus figured it out and whipped Philips into shape to make it happen. And now Philips is offering it to everybody with Epic, but I think we were pretty early on that curve. From a workflow standpoint, though, I do think with my conversations with a lot of these vendors, they treat all DICOM images the same, and a chest x-ray is not a CT, is not an MRI, is not a 3D reconstruction, and if you've got a specialist looking at a 3D reconstruction of the knee, planning their knee replacement, they're not going to wait for it to load from a cloud. It's just, I mean, I don't want to say never because we have amazing technology we didn't have 10 years ago, but with current technology, they're not going to wait.
What about remote access of images? As you look at the workflow, to me, I think of the workflow as, people outside of the hospital, clinicians perhaps needing to access images from home so they can consult back into the healthcare organization. How are you managing that?
Well, our enterprise doctors have their own access into our PACS itself, but I was just up at the show. So our local HIE has been in place for a long time. It was a military collaboration with the Chamber of Commerce, and the vendor is a master of direct secure messaging, and so we expect by the end of the year we will be doing our image sharing to physicians in the community through direct secure messaging and extending direct secure messaging from just medical records into allowing them to really view their images and get those. Now they may not, they will have to wait, but if they feel it's worth it, they'll go get it. And it's not something that they do 100 times in the day where they're waiting for that image. It's that one-off call where they know there's an image that could help them deliver care. So we think that they'll use it.
And for us, our providers, they can access the images from home. They have to utilize VPN via the secure message and the secure tunnel that gets them directly into our network.
Ours use Citrix to get into the EHR. Our radiologists can actually launch iSight through Citrix. We are also using ImageWorks, their Lila products, or LifeImage. Their Lila product to have a zero download viewer for our neurologists to take call. There are 7 neurologists that cover stroke call for the entire state, so they're not always in the hospital. So we push images to there. It's a zero download viewer. It's not diagnostic quality, but they can look at it on their mobile devices and make calls about whether or not they think the patient needs to be transferred and make plans for IR labs to be open even if they're on the soccer field.
I want to focus on something, and again, Michael, I think it was something you said, counting clicks, that the docs are going to count every click that they need to take to make sure that they can access the information. And that leads me to a question of how do you assess that the environment that you set up and the way that clinicians are able to access the images that they need to access, that your clinicians are satisfied? And do you do any sort of formal measurement around that process?
Well, when they're not satisfied, they usually tell you, so you know that part. That's easy. I think there's no one strategy. I mean, I think if you hear people talking about change management or engagement with physicians, the minute that someone stands up and says, "I've got the solution and here it is," it's wrong because there's not one thing that you can do. Physicians are highly intelligent, capable people, but they have, in many cases, a very unidirectional view of their role in the organization. So you need to understand that and work with it at different levels. So at our hospital, we have an MAC, Medical Advisory Committee, that all our senior management attends. We've invested in a CMIO role, which is really helping with our EHR transformation, and we rely on embedding physicians generally into all our EHR projects on a fee-for-service basis. So obviously we engage them in projects, but when it's so significant that you actually need them to sit down and provide order sets or work with them on workflow, we say, okay, we'll pay you for a day of your time a week and get them involved. Because doing it on the cheap or in the hallways only leads to additional frustration because you don't usually get enough time to get that engagement. So, and that's what you need to know. Like I said at the beginning, you know when they're unhappy, but to know that they're happy, you need that engagement because they will quite naturally take for granted the things that work well and focus on the things that don't.
Are others formally measuring how the workflow is working and ensuring satisfaction of the clinicians?
So we've tried to formally measure through surveys, and what you get with surveys in our experience is the negative docs that have something to complain about fill out the survey. The docs that are satisfied don't fill it out, and you have very, very few docs that think what you're doing is so fantastic that they're going to take 10 minutes of their time to tell you how great you're doing. So if you're trying to measure how many people are mad at you, it kind of works. We do have some lean processes where we actually send someone to do shadowing and timing metrics with them, but it's a very focused effort on an area that we think is a problem. And we kind of go with if they're not screaming, they're okay with it approach. We do meet with them regularly.
Yeah, the McKesson system, where I was when I worked at Spectrum Health, the McKesson system actually could tell you the amount of time it took for the image from the click to the load. And so we would look at that, and really a lot of times the doctors were overemphasizing or exaggerating. But the way I look at physician satisfaction, and it sounds defeatist, is you just want to make sure they're not so dissatisfied that they complain, that you're not the biggest problem of their day. And I think that's doing pretty well with physician satisfaction if they're just able to use the tool and not have it ruin their day. And we round a lot to make sure that happens. We round a lot and just ask them, how you doing today?
Okay.
We don't do surveys anymore for this specific example that you get all the people who hate you and want you to die will respond. But what we do is we have quarterly town hall where our general actually have IT, all the IT leadership, self included, stand in front of everyone and listen to all the great things that IT has done lately to advance their lives. And all of the large higher level committees like the Board of Directors, the Executive Council of Medicine, which are the docs, the Executive Council of Nursing, which is nurses, as well as the I think it's clinical care support, which are ancillaries. IT staff and IT leadership actually attend those meetings, and part of their agenda is to let us know what can we do better, and for us to also explain to them what we're doing to help them.
And along those lines, whether it's CPOE or PACS or anything, what I've developed as an approach, if I hear a lot of feedback that's negative, usually I actually don't hear that from the doctors. I hear that from administrators who heard that from doctors, right? Because we have a lot of people out there talking to all our doctors all the time, and it's sort of, they use IT in many cases as a sort of a pile-on. You're doing this to me, you're doing this to me, you're doing this to me, and oh, by the way, I don't like that either. And it's very effective. I just go back to the administrator and say, just get out and round. So whatever you hear from anybody, go out and round yourself and see the doctor, talk to the doctor, and then come back with an opinion. So that's what I'm concerned about, our executives' perceptions of the doctor's satisfaction, our board members' satisfaction with the perception of the doctor's satisfaction. So if they get out and around, though, they get that balanced view, and they see how the doctor's using the systems. Almost invariably, they see how it's improving care, and it gives people a balanced view. It's all anecdotal, but it's one-on-one contact.
Right. And one of the things we do for that is we have some late adopter physicians and nurses who don't like technology at all, and some of those who are going to hate anything. If you turn the light switch on different, they're not going to like it. That we actually go out to those people and help. So we have this new whiz-bang idea. We go out to one of those late adopters and say, listen, we want you to try it. I'm going to help you through this all the way until you're able to do it, and actually end up having them as our speaking piece, because everyone knows that if Dr. A says, oh, this is great, that yes, it has to be great, and IT is helping.
Well, in the next few minutes, I'd like to shift gears from what you're currently doing, and I'm curious to understand what your future state looks like. So, as you're looking at continuing to evolve your imaging environment at your organization, what sorts of things are you looking at doing? Are there new areas that you're looking to digitize? What direction are you going in the future?
So our Our biggest direction probably is telehealth. About 12 months ago, the Mississippi legislature passed one of those rules that said you must treat all telehealth visits as if they are regular visits if you want to be a licensed insurer in the state. So now we are having all kinds of requests for us to do telehealth visits. I'm trying to figure out what to do with those videos. Pathology is really big, as most of our rural hospitals are maintaining a pathologist for the couple slides a month that they have. We have a number of places that have a rotating radiologist or pathologist where they get pathology reads or radiology reads on a Monday, a Tuesday, or a Wednesday, and they're looking to centralize and get 7-day-a-week service. So our biggest challenge is how to not lose money on these propositions from state-run critical access hospitals or public health centers, because we're all one big state group, and still make our bottom line and pay for our hardware.
Well, I think that highlights the big problem if you're not in a real urban area and you're in areas like Mississippi or the Panhandle, that digital divide is very real, and what those remote hospitals can afford and then access in today's day and age is very different, and it does make you get really creative with strategies on services you really maybe even can't provide some places. So that is a big part of our plan.
We're just moving more towards telehealth. We do telehealth now with some of the facilities that are overseas, but not much locally, but we're moving more towards a local telehealth.
John, are you concerned, so as you do things, one of the things you mentioned was the videos, kind of the video consults, and are you looking at archiving those kind of consults in the same way, and how are you, because I guess they get treated in the same way as images as large files, and how you're addressing, because it seems like that would add a lot of volume.
They do. So because of our access problems, we have critical access hospitals that the most they have is a 56K modem. They don't even have DSL run out to them. We have paid to run lines out to some of the hospitals. I mean, the Delta of Mississippi is infrastructure poor. I mean, it's amazing. You drive through there and people are living in shanties with tin roofs that don't have power. Those areas are really interested in a store and forward approach, because then the timing doesn't matter as much. So if it takes 3 hours to get to us because they did a CT scan, then it's not such a big deal. Or if they did a visual light exam and it takes overnight to get to us. And those are actually timings that we've been looking at and talking about. But if we start accepting them, how do we archive them if they're not, quote, our patient? How long do we have to store them for? What are those retention policies? Who is responsible for storing the image long term? Who has to do the medical record release? Those questions we're currently working on answers. But our biggest concern from a technology standpoint is, if we have to store them, where do we put them? And how do we continue to afford to put an entire state's worth of high density images someplace?
Mm-hmm. I think that was a great point. It's, okay, whose responsibility is, if you're kind of facilitating it from that perspective, are you ultimately responsible? I really appreciate the great comments that we've had today, but I'd like to turn it over to you and get any comments or questions that you have or things that you're interested in having our panelists answer on your behalf today. So the question was, is anyone doing telepathology and streaming of the pathology images?
We just started. And it didn't go real smoothly, so we're still trying to figure it out. Might be able to better help you in about 3 months, because our backup plan was our chair of pathology drove down and got the slides and brought them back up. That happened more than once. And it came into infrastructure programs. We hit circuits that we didn't know weren't going to carry the bandwidth, because the hospital had the bandwidth out, we had the bandwidth in, but there was a bandwidth divide between us, and because I think they were 2 metro lines that didn't connect, and so we're really struggling with how do we do that streaming, and I actually think we are not doing it right now. If I understood my last update correctly, we hired a courier to just bring us the slides because the image plan didn't work. So that's probably not the answer you were hoping for.
I was going to say, we have the technology to do it. However, there's this great information assurance certification that you have to have in the DoD called DICAP that typically costs an average vendor over $100,000 to actually get the certification. And without it, we don't allow the software or the hardware on our network. So it can be VLAN or, on a shelf or on a desk by itself, which some of our child sites actually have, but because the software, the hardware is not die-capped, we won't allow the data to go back and forth. Unfortunately, we're attacked by China minimally 120,000 times a day, our network.
Okay, other questions? Is the patient engagement, and how do you engage the patients and make sure that, you've got the infrastructure and such in place?
Well, we really haven't considered in our patient portal that we were going to put images online. Our extent of patient engagement, although it's a good thing to consider, right now we do get way more patients coming to our radiology department than I expected when I was rounding and learning about that, and we just give them the files on USB. So it's really still a manual process, and we can do that in a heartbeat, and we've got all the processes set up. And it happens with some frequency, but it really is just a USB.
John, what about you? I'm curious to understand, because you probably get kind of a reverse situation where you probably have a lot of patients coming into your environment with images on USB, and how you're addressing that and trying to figure that out, and reading images that might be in different formats. So
Yeah, so we have rolled out in some small venues very successfully the Lila product. It allows a single viewer, regardless of what viewer is on the CD. It's a fairly quick upload process. Our neurosurgeons actually put the CDs in themselves and pull up the images. They do have from there the ability to archive to our PAC system. So if they're going to use that image for a surgery or follow a growth or a tumor, they can push it to our PACs from there with a single click. So it's been very successful there. It's a fairly laborious back-end setup, which has slowed down our ability to roll it out. We did roll it out to our stroke providers as well, so that those images are able to be seen on their mobile devices. But mostly, we still have people taking that USB, running to a radiology tech and asking them to load onto the PACs so that they can see it.
Michael, the same in your environment?
Yeah, pretty much. We're just at the forefront of developing a patient portal strategy where we can have people accessing their charts. So I think from an engagement perspective, that's what we'll look at. We haven't decided if we're actually going to do a lot of imaging on that. It's one thing to say, your grandma's creatinine level was up at 200, as opposed to having like a 128 slice CT on your iPad, right? And I think that for us at our hospital, we want to ensure that when patients are reviewing their chart or the charts of their loved ones, they have the ability or the resources beside them to interpret what they're seeing. And so from an engagement perspective, we feel that being patient-centered is important to give information out, but that has to be in a context where they're supported in interpreting and understanding that information, because sometimes a little bit of knowledge gets you into trouble.
So it sounds like there may be a differential between actually sharing the image through the environment versus sharing the summary, or the radiologist's summary of the image, which is giving some more succinct information that might get the patient, because they can at least read the black and white language.
Yep.
Okay. Yes, ma'am.
Just from a feasibility standpoint, how much data are you?
So the question is the differential between the streaming pathology and another type of data file, and what's the size differential?
So I'm going to try to remember the conversation I had with my radiology analyst and my laboratory analyst and get the number right, but it's at least tenfold over the standard CT scan. So, you start pulling on some of the 3D reconstructed MRI stuff, they get really big too. But if you compare them to like a chest x-ray to the pathology, it's 1,000-fold or some ridiculous size difference. So they are much larger.
From that perspective, John, are you triaging, for lack of a better word, to do it how you're, as you look at things like patient portals or other means of data sharing, like the images you're sharing just from a size perspective, and is that playing a role into how you're sharing things?
So our sharing is mostly based upon what we think is the right thing to do for the patients in the state. So when we need to figure out how to get CT scans shared from the rural hospital to our stroke neurologist, we get that done, we figure it out. So it's really more of the business case or the clinical case than it is what's going to be easy or hard. It's all kind of hard.
Other questions from the audience this afternoon? Yes.
I'm a multidisciplinary cancer center, and we're looking at expanding this, looking at other business opportunities. Do you all have any expertise or experience in
The liability on that is larger than you think. So that's what I'm going to go from that, having been through some of those. If you find a subtle abnormality, you are then responsible for making sure everything gets followed up, or you are part of the responsible party with the suit. We have several litigations with that. We just had a presentation today with somebody else talking about the litigation that they had from those pre-screenings. You find a nodule, you find a slightly elevated level. So the retention policies there are going to be long. I mean, whatever the standard is, probably at least double if you talk to your attorneys. Because if you found a lung nodule this year and they came with metastatic lung cancer in 2024 and you say you threw out the image and you didn't follow up, not sure what your attorneys are going to say, but you're going to be part of the suit. You might win, you might not have to pay money, but you're going to pay legal fees.
All right. Well, I wanted to thank everybody for joining us. I'd like to thank all of the members of our panel. Hopefully you've all found this to be informative, and enjoy the rest of your afternoon. Thank you very much.
Great to see you, John.